Thank you very much. Okay, I know you're all here for the most important talk, right? Yeah. This is the one you've all been waiting for, surgery. Then there's a big letdown, right? Well, I've given a talk similar to this. I think it was 10 years ago. Same topic, but what I decided to do this time was to give you all the updates. So I'll go over some of the stuff that we knew, but I'm mostly going to be emphasizing updates, things that we've learned over the past 10 years. And there's been quite a bit here. Okay, so basically, DBS is a treatment by which there's an implanted electrode in the brain that gives stimulation to the part of the brain, and it produces therapeutic results. And this also depends on where in the brain that you are putting the lead as to what you're treating and what kind of results you're going to get. Now, most of the time in the world of movement disorders, we use DBS for Parkinson's disease, tremor, and for dystonia. But there's many other applications for DBS, and I know my colleagues in epilepsy use it quite frequently for epileptic seizures and things. So this is a treatment or a type of treatment that's used for a lot of different things. Now, in the past, we've always known that generalized dystonia tends to respond better than focal dystonia. Now, what I mean by that is where in the body the dystonia is affecting. So generalized usually means whole body. So it could be head, neck, trunk. It could also include extremities and variations of that. So people who have more than one place of their body affected with dystonia tend to do better with DBS than people who have only one place in their body. And we think that's probably because we don't really know the anatomy or what they call a homunculus, or the different parts of the body imprinted on parts of the brain. So we know that this happens not just in the motor cortex, but also in the basal ganglia, and we all know the globus pallidus is where we think dystonia originates. So we think it's aberrant activity in that part of the brain. So obviously the GPI has, whoops, I just did that, didn't I? The GPI, or globus pallidus, has the favored site for treating dystonia with DBS. There are other sites. There's the subthalamic nucleus and the thalamus. And I'll talk a little bit later about what each of these do, but they're just different parts of the brain. And 10 years ago, not only did we know that generalized dystonia responded better than focal dystonia, we also felt that the GPI was the best site for dystonia, especially for focal dystonias. But there wasn't a whole lot of evidence supporting either of the other two sites. So there's been a few other studies on that more recently. At that time, DBS was helpful for cervical dystonia, maybe giving you 50% benefit. So not a tremendous amount of benefit for just focal cervical dystonia, but 50% is better than 0% if you don't have any response to the other treatments that we have, and that includes medications and the botulinum toxin injections that Dr. Torres spoke about earlier this morning. And at that time, DBS was not considered first line. So only those people who have cervical dystonia refractory to injections or medications, they would then be possible candidates for deep brain stimulation surgery. Okay, so we'll give you a little bit of background on what DBS is for those who weren't here 10 years ago. And this is your lead here that's put into the part of the brain. And here's a connecting wire. and it is hooked up to an implantable programmable generator, an implanted programmable generator. So this is the battery they're always talking about here that needs to be replaced and things. And we have updates on that as well. But this is basically what it looks like. Okay. And the surgery is usually done in 2 stages. So the first stage is putting that electrode in the brain. And that's probably the longest surgery that there is for this particular procedure. Most of the time, if you have this done, you are admitted overnight in the hospital, and then you're discharged the next day. And then 2 weeks later, they then they hook up the wires and put it down into and implant that programmable generator. And it's usually put just underneath the collarbone. And they generally reserve DBS for the right side of the chest, because the left side is in case you need a cardiac pacemaker or something. And some people have both. So, new things. Stage 1, where they put the lead into the brain, it can be performed either while you're awake or while you're under general anesthesia. That's a big change, because it used to be you had to sit there awake while they're doing all these things in your brain. And you know, some people can handle it, but other people would freak out on that, because it's a really odd thing to think about. But yeah, so now they can actually do it under general anesthesia, and we use what they call microelectrode recordings to ensure that the electrode is in the proper place. So before they actually implant the electrode, the neurosurgeons do a lot of research. They look at your brain, your MRI scan, they measure things, and they calculate the actual coordinates that need to be put in. And so they do a lot of this beforehand, but they would always use the patient being awake and how they responded during the surgery as kind of like their confirmation they're in the right place. So now that we have this microelectrode recordings, we know they're in the right place. So you don't necessarily have to be awake for the surgery. You can actually be put under general anesthesia. Okay, so that's one change. The other thing is the DBS batteries. Now, if you've ever known anyone who had the older DBS batteries, they were relatively larger, and you would need to have a battery replacement for dystonia within like 2 years, because you need higher levels of stimulation to actually get a good result. So these batteries would be changed every 2 years. Now, when you change those batteries, remember, it's under the skin, under the collarbone, and that has to be surgically removed and a new one put in. And so sometimes people would have 2, 3, or more surgeries just to have a battery put in to keep their therapy going on. Well, now we have a rechargeable battery that can last up to 15 years. And I say up to 15 years because I didn't test it for longer than 15 years. So they could last longer. We don't really know. They just stopped the studies at 15 years. And I would fully expect that they probably do last longer. Now this is a guy wearing one of the newer things that recharges the batteries. So on him, over here, there's like a little disc underneath, and you take that disc, you plug it in the wall, and then you put it in this little thing that goes around your neck, and then hold it, just hang it over your DBS, and it charges itself. Okay, simple, right? And it used to be not even too long ago, just even a couple of years ago, that you would have to charge this like either 15 minutes a day or like a half an hour to an hour a week. Now, you only have to charge it once every 2 weeks, depending upon the level of stimulation. So another improvement, so this is actually better, gives you more freedom, but this is actually a pretty decent compared to having surgery every 2 years. Now the battery replacement is an outpatient surgery, so you go to the outpatient surgery place, the same day surgeries, and then you go home later that day. So that one you are put to sleep for during the surgery, and then you go home later that day. So it's not as invasive, and you don't have to have the first part where they put the electrode in the brain repeated. So that's good too. Okay, now this gives you a little idea of the anatomy of the brain. And we have 3 sites. Remember I told you there was the GPI, so that little triangle part here, that's the globus pallidus, and the I stands for interna, that's just the Latin name for it. And then we have the subthalamic nucleus here, because it's underneath the thalamus here. So VIM is for the ventral, the motor nucleus of the thalamus, VIM thalamus. And then STN is subthalamic nucleus. Okay, so you have a little idea of where these things are. And then here on this side, it shows the electrodes into each of these little parts of the brain. Okay. So what do we use these sites for? So basically now, the thalamus is known that it's very good for tremor, but not good for much else. So it doesn't actually treat other signs of Parkinson's, the slowness, the stiffness of Parkinson's, or the gait changes, but it will help if they just want the tremor fixed. The GPI, the globus pallidus interna, is better for dystonia, but it can also be used for Parkinson's patients. And some Parkinson's patients actually have dystonia as part of their illness or part of their what they call dyskinesias that are caused by the medications that we use to treat Parkinson's disease. And then the subthalamic nucleus is what we think is best, but it's just the most often used for treating Parkinson's. But we've had some more studies recently that show that it can also be effective for treating dystonia. So a little bit more surprise there. Okay, so like I said before, more updates. We know that generalized dystonia tends to respond better than focal dystonia, like cervical dystonia. However, now we're looking at the degree of therapeutic improvement. Now remember, it was around 50%. 10 years ago, it was up to about 50% improvement. That has increased. It has increased, and most of the recent reviews or meta-analyses that have been reported have shown 47.6 to 70.2% improvement. And we'll talk a little bit more about what that improvement means. And a recent estimate from 2024 actually used 20 to 80% improvement. So the degree of improvement is getting better. Okay. Now, it's still true. Now, they always had, what they found was that the phasic parts of dystonia tend to respond first and better to the DBS than the tonic parts. So what I mean by that, phasic is when you're turning your head and your head kind of jerks. Now, we're not talking about tremor because dystonic tremor is also an entity, but this is part of the dystonia, so part of that movement. And tonic is when your head is turned or in a certain position and you really can't change it and it doesn't have much movement to it. So what we found is that the phasic components, or that jerkiness, that movement, responds better than the tonic parts of it. And we'll talk a little bit more about that as well. Yes?
I'm a little confused. That second bullet shows like 47.6 to 70.2%
Yes.
improvement.
Yes.
And then it said with recent estimates from 20 to 80%.
Yes.
That doesn't sound like an improvement from 47.6 to
Oh,
You understand that?
it is improvement, and I will talk a little bit more about what that means. Improvement in therapy, and it's based upon the studies and what they use to evaluate patients in the studies. So yes, like I said, the 20 to 80% improvement is from a recent analysis. And I'm not really sure where they got that number, but most of the literature reports 47.6 to 70.2% improvement. Okay. The other two things that we don't know about from all of these studies is there any improvement in dystonic tremor? Now, dystonic tremor is not always included in these studies, so patients may or may not have tremor. And dystonic tremor can involve the head, but it more often involves the hands and the arms. And dystonic tremor can look like regular essential tremor, or it can look like a Parkinsonian type tremor, but it is an irregular movement, and it tends to have a jerky quality. So that's how we know the difference. Plus, the tremors usually are in the part of the body that has dystonia or one that's adjacent, like the arms in cervical dystonia. So some people have it and some people don't. They're not really sure about why some people have tremor and why some people don't. And the mechanism of the tremor, the pathophysiology, is not known as well. And they are doing more research about this year. Because I heard this last year at a meeting, they were talking about this as being a whole new area of research. So this will be coming up a little bit more. They'll define it a little bit better, and then they should be included in future trials of dystonic tremor with DBS. The other thing that is not well known is the posture. Now you remember that slide where they showed you all the 4 postures of dystonia: anterocollis, retrocollis, torticollis, and laterocollis. None of those are reported in these DBS studies. So sometimes when they go case by case, because sometimes the case number is limited, like 10 patients, they can put those in the study. But for the majority of the studies, they don't list it at all. So we don't really know, is there a certain type of cervical dystonia that responds better to DBS or not? So we're kind of at a loss with that one. Whoops. Come on. Okay, so now, when I was telling you about the percentage of improvement, we're getting to that part. What that is based on the total TWSTRS score. Now, TWSTRS stands for Toronto Western Spasmodic Torticollis Rating Scale. And this is what they generally use to determine how a person is doing with cervical dystonia. So it comes in 3 parts. One is the severity of the dystonia, or the amount or degree of abnormal posture. One is on pain, and one is on disability. So these 3 parts are put together, and that's called the total TWSTRS score. So they are actually taking into account pain and disability when they are measuring this on patients in these studies. So when you're looking at that percent improvement, they're looking at the total TWSTRS score before they had the surgery and then after the surgery. So this number could be anywhere from like 2 weeks after the surgery to a month later to even 2 months later. We don't always know exactly when they measure that. And sometimes there are some long-term follow-up studies where they do the baseline and then the last visit, so like 5 years down the road. So it's a little bit different, but basically that's how they're measuring it. Does that answer your question?
It does, thank you.
Okay, good. All right. So the one thing we know about motor improvement with cervical dystonia and DBS is that it's variable. Some people have excellent response, and I read of 2 patients in one of the case series where they had 100% improvement in the position or the posture of the neck. 100%, that's unheard of. And then there are some that have less than 25%. So this variability, I mean, that's extreme variability. So why are we getting this variability? And these 0 to 20 or less than 25% of improvement is considered a non-responder to DBS. And there's probably maybe, most of the studies, they're like less than 1% of patients in the study that are considered non-responders. Most of the time, it's like 1 to 3 patients in a study that just did not get the full response. Now, they have some studies, there's about 4 studies that have looked at predictive factors, because that would be very helpful if you could say, oh, well, this patient will do well with the DBS, and this patient won't do well, if we could figure out what would be predictive factors for this. However, the majority of studies that were done didn't find any predictive factors. So there was no change or difference between the gender, the age, the duration of disease, the severity, no difference. However, one study found a reduced response that tended to occur with patients who were older at the time of their surgery and who had a longer duration of disease. So is that a possibility? It sounds plausible. So you would think people who've had cervical dystonia for 40 years may not get as much improvement as someone who's had it for maybe 1 or 2 years. It just kind of is reasonable, but we don't really know whether that's the case or not because that was only one study that showed that. And another study, again, one study, showed a reduced response with those patients who have a shift. So we know those 4 positions, the anterocollis, retrocollis, torticollis, and lateral collis. Well, this is a shift. So you can see that if you draw the straight line from his chin, it's off to the right from midline, where it should be. That's a shift. So he has a lateral shift, kind of like those Egyptians doing the head movements, right? Or what is it, dance like an Egyptian type thing? That is a shift, and that's how I tell my residents how to remember it. But anyways, that's a lateral shift. Now, the other type of shift is forward or back. That is a sagittal shift. So you could be lateral or sagittal. And usually you would know this is change from the neutral posture. So that study showed that patients who had shift had a poorer degree of improvement as well. But again, this is only one study. Now, another thing that has been found that's a little bit concerning is that pain is disconnected from motor improvement. So, and this is not in everybody who has the DBS. In fact, it's a small proportion of patients who still have pain, but a significant improvement in neck posture. So we've always thought, improve the posture, you're going to improve the pain. But that's not necessarily true. So they've looked at different reasons. We don't know 100%, but we think it might be that the anatomy that controls the motor symptoms is separate from the anatomy that controls the sensory symptoms. In other words, there's different subgroups of neurons or pathways that are involved in processing and modulating the motor and the sensory, somatosensory function. Now, one of the things that they mentioned in the studies is that occasionally changing the electrode settings could be helpful with the pain. So in those cases, they've had more pain, and the pain still persisted despite improvement in the motor response, if they changed the electrode settings or the programming, it tended to help them with the pain. That is a good thing to try. However, again, we don't really know the anatomy, the somatotopic organization of the globus pallidus. So if we knew that a little better, we would be a lot more specific in treating cervical dystonia, and we'd be much better at that. And that would also help us with the programming as well, because we can now isolate different areas of the brain, and we can use electrodes that will focus in one area. But since we don't really know what that is, we can't really use that too well right now. Other factors could also be contributing to pain, because as we know, cervical dystonia accelerates degenerative disc disease or spondylosis, radiculopathies, you have nerve pain and things like that. So maybe that's also contributing to the pain that they're having in these studies. And that would not be helped by the DBS, not initially anyways. We would hope that correcting the posture would reduce that, and that would be better. But, you know, again, we're not really sure why this occurs. Okay, so when we come out with all the studies, we know that the GPI and the subthalamic nucleus are actually good sites for cervical dystonia. However, the thalamus has not been helpful for dystonia. So we can rule out one site. But the subthalamic nucleus actually has a pretty good response rate. So in those patients who do not have it in the GPI, the STN is also a good possibility for them. And one of the things that they think, this is all theoretical, it's not definite and proven, is that the GPI is better for the tonic dystonia, or the dystonia that doesn't have that phasic or jerky quality, and that the STN is more responsive to the phasic components and maybe more responsive to pain. So that might be another thing to consider if you have your DBS done. You want to look at the different sites that they're going to put it in. Okay, now another thing. Now that we've brought up subthalamic nucleus as a possible site, we know from Parkinson's studies that it can affect the cognitive function in patients. And that is why when you get DBS, if you're a Parkinson patient, you go through neuropsych testing before they actually will allow you to have the surgery done. So what they did, they studied the cognitive fact, or they studied a verbal fluency test in patients with cervical dystonia. Now, verbal fluency test is basically saying how many words can you come up that start with the letter F, or how many words can you come up that start with the letter A, and then you list all of them in 1 minute. And most people can come up with quite a few, you'd be surprised. And the norm is about, if you're college educated, about 20. So you're looking at how many words you can come up with that. Now, patients who have cervical dystonia tend to have a little bit of a reduction in the verbal fluency test results, just to begin at baseline. And so they tested patients before they had the DBS and then after, and they found no change in the verbal fluency test. So it appears that the deep brain stimulation surgery does not affect the cognitive factors. So that's actually a good thing. Now, duration is another one, and duration of effects. I mentioned 5-year studies. Yes, there are several 5-year studies, and they all have shown that the response to the DBS has been carried out for 5 years. And there are some that have patients who've had it for much longer, 8 years, even 10 years. So we know that the response is long, and it's very helpful for patients. Okay, so another thing that we want to look at is, why does the DBS work? So they've done some research on that as well. And right now, what they feel, this is all theory, it's not proven or anything, but this is the prevailing thought, that most of them, or that the DBS stimulation disrupts that aberrant activity that's generated from the globus pallidus interna, but also from the subthalamic nucleus. So that's also a change. But honestly, they really don't know. Okay, and I bring that up because there are new studies. With the advances in DBS, Medtronic now has the ability to measure brain waves. And this has started with the Parkinson's literature and the studies. So with Parkinson's disease, we know that a beta waveform is found when the symptoms of Parkinson's are there, and when the beta waveform is not there, the symptoms are better. And in this little diagram here, here's the beta waveforms. They're pretty fast, 15 to 20 hertz. Okay. Now, recently, they have found that there are theta waveforms in both the subthalamic nucleus and the globus pallidus in patients with dystonic activity. And the theta waveforms are right here. And that is like 8 to 12, I believe, or 8 to 10, or no, 4 to 8 hertz. Can't read it. 4 to 8 hertz. So it's much slower activity, but it's also activity that we didn't even know existed before. So when you have DBS stimulation, these waveforms tend to change. They tend to reduce in the duration, or how long these bursts of theta waveforms are, and their amplitude. They get smaller. So it just shows that DBS is helping, and it's doing it by these waveforms. So this is actually how we have come about with adaptive DBS. Now, adaptive DBS has just recently been approved by the FDA in February of this year. So I believe it was February. Anyways, so that is something that can be used with these brainwaves. So remember, I said theta waveforms that come when you have dystonic symptoms and go away when you don't have dystonic symptoms. So what they can do is use that to turn the DBS on and off according to your symptoms. Whoops, where's my other slide? Yeah, there we go. So this acts kind of like a thermostat. And this is a thermostat, a modern thermostat here. So you have, this is what you're set it at 71. This is the ambient temperature at 73. And you're on probably air conditioning at this point. So what is the thermostat going to do? When the ambient temperature is above 71, it turns it on. And then when it goes down below 71, it turns it off. Right? So it's the same kind of effect that they're doing with DBS. And this provides a very personalized therapy, because some people are going to have a lot more waveforms than others, and they're going to need a lot more stimulation than others. And this will help not only to prolong battery life, but we don't really know if there's any effects to having too much stimulation or having constant stimulation. So we're all expecting good results from this. Okay, so that's our update. So in conclusion, we know that DBS is an effective treatment for cervical dystonia, especially with motor symptoms. However, the outcome is variable, and we really don't have any definite predictive factors. Possibly increased age at time of surgery, possibly increased duration of disease state, possibly shift that may influence whether the DBS is helpful or not, or as helpful. We know that pain improvement does not always correlate with the motor improvement, and the duration of benefit is long. And we know the studies have shown, several studies have shown at 5-year follow-ups, with some 8 years and even longer. And our future of the targeted therapy with adaptive DBS is now available. So next time anyone speaks about this, they're going to tell you results from the adaptive DBS. Okay. However, when you look at all this data, botulinum toxin injections still remain the first-line therapy for cervical dystonia. It's a tried and true therapy, and if you do well with that, then chances are you're not going to want to risk having brain surgery for DBS. But if you're not able to have the injections, or maybe you're not responding to the injections, and that's with the different toxins because we now have another toxin to try, then DBS might be an option for you. And also for those who have greater severity of cervical dystonia, you get maybe partial improvement with the botulinum toxin injections, but maybe need a little bit more. This could also help you with that. Okay, and this is my sister's dog, Mabel, and she's wearing her sunglasses to remind you to enjoy the sun out here in Las Vegas and wear your sun protection.